Okay, why don't we get started? Dr. Kumar, do you want to start?
Sure. Welcome, everyone. This is our quarterly PGN meeting. I'd like to start by stating the conflict of interest disclosure. It is my duty to remind you that AMDA, the Society for Post-Acute Long-Term Care Medicine, maintains an official policy with respect to the disclosure of bias and potential conflicts of interest and related party transactions. If you have a question about whether you should make such a disclosure and you're about to participate in a meeting where that conflict would apply, you should ask the chair of the meeting whether you should absent yourself or not participate in the discussion for its duration. So we have Chris to talk about flu guidance.
Yep. Hi. Thank you, Rajiv. Hello, everybody. I just wanted to make you aware of some recent new guidance that the AMDA Infections Advisory Committee has come out with, approved by the board just last month. It really is a strengthening of our existing position, recommending that all healthcare facilities, in particular nursing homes, vaccinate their healthcare personnel. As we're gearing up for flu season in particular, this becomes important. What you see on the screen is a flu resources page that we've set up that includes a session from this year's annual conference. There will be others that we add as they become available. A link to a column that I wrote for McKnight's doing this, the policy statement itself on flu vaccination of healthcare personnel. And then some useful guidance that has come via CDC to help people facilities in particular, who are thinking about setting up a flu clinic in their facility. A white paper talking about results of a meeting on immunization practices that took place earlier this year. And then an influenza vaccination honor roll for post-acute and long-term care. This is something that has been in place. The Immunization Action Coalition set this up some time ago, and really it related to any healthcare organization, but we asked them for this flu season, to break out a separate one for post-acute and long-term care. You can see it on the screen here. There are very few, as you can see, out of 15,000 nursing homes, there are very few that have signed up for this, and I think it'd be some good news if we could get more facilities to who we know are already doing a pretty good effort to get their personnel vaccinated to sign up for this and kind of show their leadership. At any rate, this is available to you. It's free to not only AMDA members, but anyone who comes to the resource. We have taken off the various paywalls that are in front of these resources and want to make them freely available. We're also publicizing them pretty widely, as is CDC. CDC has been working pretty closely with us on this as we approach preparation for the upcoming flu season. I think that's all for me, Lori.
Next, we have Alex Bardock, Director of Public Policy, to talk about physicians' fee schedule.
Yeah, thanks, Rajiv. This is Alex Bardock, Director of Public Policy. So we just on Monday, on September 10th, submitted our comments on the annual physician fee schedule. This year's fee schedule included two distinct proposals. One dealing with the documentation requirements for E&M, evaluation and management codes, and the other with the quality payment program. So on the first point about the documentation requirements, probably everybody has seen articles out there, and a lot of CMS did a lot of press around this in terms of burden reduction. But one of the things they did is not only did they address documentation requirements, what was most controversial is collapsing the office-based codes and coming up with one rate. So there've been a lot of reactions, discussions. AMDA has participated within the American Medical Association's process through CPT in a panel known as the RUC, which sets the values for the codes. And so we've signed on to several letters, one by that AMA group, another by a medical coalition of medical specialties organized by the American Geriatric Society. And the overall position was that collapsing the codes really hurts those that are seeing more frail and complex patients because the higher level codes are now going to be valued at a much lower rate. And there are other problems with it as well. You can read all of that. We have it in our comments. There have been, as I mentioned, a number of articles. And so if you have questions about that or more specifics about that, we're happy to answer them. As to what happens moving forward, again, this was a proposed rule. So CMS will have to evaluate the comments they receive, and I'm sure they've received many comments on this issue, and they have to issue a final rule by the beginning of November. So it's unclear exactly where CMS will go. There had been a number of meetings with them about this, but it may be that they keep some of the documentation requirement burden reduction things, such as being able to choose between 97 or 95 documentation guidelines and removing some of the past physical history or things like that. So they may remove some of the documentation requirements, or they may reject the entire proposal altogether. So we'll see in November. But regardless of that, the CPT RUC has developed a work group. We have Chuck Crecilius and Dr. Raj Mahajan who participate in that process, and they're going to be developing a new proposal and studying some alternative methodologies for not collapsing the codes, but coming up with a different way of valuing these codes and making sure that it's looking at maybe billing based on time, or is medical necessity or just medical decision making the most important thing. So they'll be looking at all of those things, and we'll be participating in that process. Just to remind everybody, this again had dealt with office-based codes, so the skilled nursing facility codes are not a part of this proposal. One of the comments we made is that if this is finalized, you're now going to have different sets of rules, one for office, one for skilled nursing facility. And a lot of what is being studied right now has to do with office space. They're not doing anything with inpatient codes, be it the hospital or the skilled nursing facility. So we'll see. The thought process is that down the line, if CMS were to finalize this, they may address the other E&M codes. But just to be clear, this is only dealing with office-based and not skilled nursing facility codes. So that's what was going on evaluation management front. Equally, there was a lot of proposals dealing with the quality payment program. That is your favorite MIPS and APMs. There were several proposals with MIPS, mostly I would say marginal changes. They're not huge changes. Same type of requirements for reporting on 4 different categories and that sort of thing. A couple of highlights, however, on this, and victories that we had, and with the help of Practice Group Network and our practice management section, CMS will now publish, or proposed to publish, a set of SNF-specific quality measures. Now, to be clear, these are existing measures that have already been in the program, but CMS will take our recommendations, others' recommendations, and actually post a SNF-specific set of quality measures under the specialty sets. So in the past, they had all of these different specialties, and they would publish recommended measures for those specialties, but they had nothing for those practicing in SNFs. And so, of course, we got calls all the time about that. And the proposal was for SNFs to publish that. This is something that AMDA asked for several years, and so that's coming to fruition, hopefully, if it is finalized, and I can't see a reason why CMS would not. The other big part in this year's proposal was CMS's request for information around what's called facility-based scoring. That is that instead of reporting into MIPS, the clinicians would simply have the ability to choose to take the facility score, so your skilled nursing facility score, and have that be as part of your MIPS score. There's a lot of challenges with that. We responded to it and saying that essentially they need to be flexible in that approach. It's a voluntary thing, and that they need to pick about 3 to 5 measures out of the Impact Act that makes sense, and we listed them out, whichever ones we thought clinicians had some impact on. So anyway, so that was a proposal. It's not final. It's not going to be final in the 2019 reporting period, but it's something CMS is thinking about. It's actually required in the MACRA statute that they implement facility-based scoring. They've already done so for the hospitalists, and so now it is moving into the post-acute care world. So I say this to be on the lookout when the final rule comes out, how CMS reacts. We're going to continue to work with them through the year, and hopefully in next year's proposed rule, we're actually going to see some, rather than questions about how to do this, some actual proposals, because we do think that that's a good opportunity for those practicing in the facility to line up what's required of them in the office setting versus what's required of them in the SNP. So we'll see where all of this goes. There were a number of other changes, namely the cost category being increased to 15%. It is for this year is 10%. We continue to oppose any increase in that category because the measures that they use, the total cost measure, is not a good measure. It doesn't have the proper risk stratification, and we actually suggested to CMS some other things that they should be including as they reevaluate that measure. So, we worked with AMA and others, and so pretty much everybody across the board is opposing any increase to that cost category. You may recall that there was legislation earlier this year that I talked about on the last call that gave CMS flexibility to score this category anywhere between 10% and 30% of your final score. So for next year, they're electing or proposing to do it at 15. Those are the big highlights from the physician fee schedule. Happy to answer any questions.
Okay. Move on to opioid regulations, Alex.
Sure. So this has come up as I think everybody's aware. There's a crisis, an epidemic focused around opioids around the country. The CDC has issued their guidelines of what they believe should be done, and we had a resolution I think 2 years ago now about this to really look at it from a perspective of what needs to happen in post-acute and long-term care. Subsequent to that resolution, there was a work group that worked on some guidance. It's now being reviewed by the board of directors, and hopefully that guidance will be out pretty soon. We had a call with our state chapter leaders and asked the different states as to what they're seeing in their states. Because apart from the federal focus on this, of course, a lot is going on in the states. They are focusing on looking at PDMP for each patient. And so various states reported different pieces of legislation that have gone through their legislature that is either making it more difficult to prescribe necessary medications for those in post-acute and long-term care, or that they have been successful in lobbying their states to seek exemptions for patients and residents in facilities. So several states reported that they were actually very successful in working with their state society, so on carving out those exemptions. So I think that the point here is that we're working to respond to the CDC guidelines. They're not universal in terms of how they're applied in all settings, but this is something that is clearly impacting a lot of practices around the country. That we submitted comments on a quality measure that was proposed around this. And again, in many instances, we seek exclusions for patients in post-acute and long-term care. So that's really where that situation is. We'll keep asking the states how they're progressing. We will provide them guidance when it comes out, and really urge, if you are involved within your states, to work with your state societies. I know in Maryland, for example, there was a lot of activity around this issue, and being involved with the state society that's actively working this in your state houses would be very wise.
Okay. Any questions for Alex? All right, Lori, if you would project the worksheet that we have for model medical director. Okay, there you go. Thank you. So, the role of medical director, with all of the changes that are occurring in healthcare delivery, has been evolving. So we have talked about this model medical director agreement, which was used as a template for medical director contracts and agreements all over the country. We thought that needs a revision. And this is a worksheet that we've kind of worked on several meetings. We've had a couple of phone calls, and also at the last leadership meeting, where we had a lot of chief medical officers from all over the country gather in Baltimore in August. We talked about it, and these are some of the issues, and we will address it again when we meet in November. And we are waiting for feedback from all the state chapter leadership, and also we thought we would open it up to the PGN membership as well, Practice Group Network. So please weigh in with your opinions, any questions, any suggestions. We value all of that. So basically, some of the items that you've talked about, if the facility is sued and if there is risk management involved, as a medical director, what can we do to help the facility? Maybe review records and make recommendations. Probably keep all of that under the wraps, under the quality committee, so QA committee, so that it is privileged information, not discoverable routinely by plaintiff's attorneys, so that we can help improve processes and maybe help prepare the facility to defend if it goes to trial. And how do we get reimbursed for the time that we put into such activities, unless we have that included in a model medical director agreement? And we thought we would also ask for legal counsel. And Dr. Walker said she had some language for indemnification clause that we're waiting for to look at. And we will definitely run it by an attorney who has agreed to help us draft his agreement. On-call hours was a hot topic. So Carl Steinberg and myself weighed in on this, the first phone call that we had. Obviously, we get paid. A lot of times it's a flat stipend. And lately with PBJ and with changes that are occurring with anti-kickback statute, more and more nursing facilities are requiring physicians to report actual time spent on administrative duties. But the fact remains that we are on call 24/7. And it is 24/7 call for administrative duties, not for patient-related issues for our patients. But if we do get called on other physician patients for which we don't get any Medicare reimbursements, then obviously that falls into the administrative purview as well. So the thoughts along this project have been that there should be a flat stipend for being available 24/7 on call. And this could be very well the previous model where we got a flat stipend per month, but then additional hours spent if you get a call for administrative duties, the meetings that you attend for administration, maybe the QA, maybe infection control, maybe antibiotic stewardship. All of those would be billed an hourly at fair market value. So there could be two layers of reimbursement. One, a flat stipend for being available 24/7 on call for administrative questions, and the backup for other attending physicians for clinical. questions. And how about emergency situations? If it is a hurricane, or if it is a flood, or if it is a fire, perhaps we should have some language in the agreement that helps define our roles, as well as perhaps define that there is a possibility that we bill for those hours and get paid for that. And also possibly hold medical directors accountable for such emergency situations if we are called in to help. And there was a comment that came up, this was from the leadership meeting, that a lot of physicians, especially old-timers, expect a certain amount, whether they get called or not, whether they get any calls or not. And that could be, kind of included in the contract by asking for a flat stipend for being available 24/7 on call. So whether it's $2,000 a month or $2,500 a month, whatever amount it might be, we could, in the contract, we could specify that it is for being available 24/7 on call. We also talked about employed versus traditional medical directorships. So Tom Haycoat, who's our vice chair membership committee, and he's in administration for a large post-acute practice, and Carl Steinberg from San Diego. They talked about it. We are finding more and more employed medical directors. Where obviously the salary is going to be commensurate with what time they spend. A lot of times the facilities bill and collect because they're employing the medical directors for the clinical services. And sometimes there are productivity elements and clauses built into the contract. So we thought we should look into that and maybe look into some typical geriatrics contracts. And if you could pull some of the data and incorporate that into the model medical director agreement, especially for the employed model. So it's a base plus a productivity-based salary. And also, should there be some continued education and certification built into the contract? And Carl especially is a big advocate for this. And I think we've gotten some support from practice management section as well. Bob Reynolds, the chair, had also weighed in and said, yeah, that makes sense. So what this would entail is that the employer would insert a clause saying that they would pay for continued education, certification, possibly and membership. This could be a checkbox, or it could be a section that could be added or deleted based on what the doctor and the employer agree to. We also had some issues about medical directors in rural areas where it's very difficult to recruit them. But if we provide some incentive for their training and certification, it might be easier to get medical director buy-in. We also talked about ISNP, Institutional Special Needs Plan, and any other setup where there is possibly a gain-sharing agreement or arrangement. And we talked about STAR clause and anti-kickback statutes. Medicare has been looking at these topics with a much more liberal perspective lately. They've even asked us to submit some comments in an RFI for what other waivers can they institute to let us meaningfully participate in these kinds of risk-sharing and gain-sharing arrangements. So this could be one of those, especially if the medical director works hard and earns the nursing facility some rewards in terms of maybe gain share savings from an advanced BPCI arrangement, or maybe with a hospital system with a next-gen ACO, should the medical director be allowed to take part in sharing those savings. And the consensus has been that as long as it is not a clear violation, and if there is substantial effort put in by the medical director, for example, meeting with the hospitals, being the face of the organization, relationship building with the acute care side, being a CMO for the nursing home, peer review, medical staff functions, recruitment of consultants. So all of the time that's spent in there should either be compensated in the hourly contract model, or if it makes a big difference in their gain sharing arrangements, there should be a mechanism by which such efforts could be compensated. And then we talked about attending physician agreements. Obviously, they don't get paid for clinical work they do, but there should be a code of conduct, there should be expectations pertaining to their roles and responsibilities. Is this a separate project, or should we work together along with the model medical director agreement? We could put together a model attending physician agreement and model APN agreement. And with the APN, we talked about GAPNA, because it's a sister organization that we collaborate with very well. We didn't want to encroach on their role in defining their functions and jobs and responsibilities, so we decided we'll collaborate with them in defining the APN role in post-acute care and possibly an agreement for them. These are sample agreements and not a contract, and the employer and the physician or the APN will decide what is going to be an appropriate contract. Then we talked about potentially avoidable utilization, the role of medical director. Example would be formulary decisions for pharmacy and the savings and the potential savings that we can make. Maybe the antibiotic stewardship program and the impact of the medical director and the savings and the avoidance of complications. Is there a price tag to that? And at least the time that the medical director spends in doing that should be compensated. And we thought about maybe creating the standard contract, and then other considerations that we talked about earlier about value-based medicine. And then maybe an app, maybe a timesheet document that helps capture all of these times that a medical director spends in all these activities, and to help the facilities meet their quality metrics. Again, going back to the waiver of some of those anti-kickback statutes, rewarding physicians and APNs for outcome-driven care, gain sharing. So we talked about that quite a bit. And Dr. Steinberg also had a comment about avoiding discrimination based on one's sexual orientation. I think it's a standard practice nowadays in most contracts to add that, so we would definitely update our model medical director agreement with that clause, and we'll look to Carl or to our attorney friend to find the appropriate clause to include in our model agreement. So what we want to do is hear back from our membership. We've asked the state chapters to talk to their members, so we're bringing it up to the PGN as well. See if you have any comments, concerns, suggestions. Please, it doesn't have to be right this minute. Think about it. And if you come up with something, email them to me or to Lori or to Alex, and we will share that with other participants who are working on this project. And once we have a finished product, we will definitely share that with all of our membership. Any comments?
And I will send the latest version of the model medical director agreement out along with these notes.
Great. Thanks, Lori. So please look it over. And I know we have a few participants today, but we'll send it to all of the PGN members and ask them to weigh in on this project, and any suggestions, recommendations that they have will be greatly appreciated. Any questions, comments, anything? It doesn't have to be about any of the topics we discussed, but it's an open session, so any concerns you may have. Anything we can do better to serve you through PGN or even through practice management section? Okay. Great. One thing that we talked about internally is based on feedback and also participation, that we may not have quarterly calls. We can definitely host ad hoc meetings anytime if there's a matter of concern. But otherwise, we probably will stick to once or twice a year meetings We definitely meet at the annual conference. But if there are any issues that membership brings up, we'll definitely hold ad hoc meetings to address them. Again, any comments about that, the timing of these calls and meetings?
And I'll send out a survey as well to the whole group to make sure that, if we have, meetings once or twice a year versus calls, that as a whole, everyone's in agreement that that's the appropriate path to take.
Great. Thank you. I think we finished early, saved a good half an hour you can put back on your calendar. So we'll meet the next time, whether it's a phone call or at the annual meeting. So have a great day.
Great. Thank you.
Thanks. Bye.
Bye.